public health was a bit on its own island and wasn't able to call a friend to get some help. And throughout history, public health, the business sector, medicine have worked together in a variety of ways. And of course, public health and medicine were one field. Years ago, they just diverged over time. But it's a bit of a humility exercise for public health to say, we do need to work with others and we need friends. And there's some things that medicine might be able to do better than we can.
Welcome to The Other 80. I'm Claudia Williams. Today I'm joined by Dr. Karen DeSalvo, a trailblazer who has worn many hats, from leading public health in New Orleans to serving as the Chief Health Officer at Google. We discuss ways AI could help public health leapfrog old barriers to close gaps we have traditionally failed to fill, but also dive into the risks, including a regulatory landscape struggling to keep up. Please welcome Karen DeSalvo to The Other 80. Hi, Karen. It's
Hi,
so
Claudia.
great to have you here.
It's nice to see you.
I'm so excited to talk about your ideas for how we move health, public health, and technology forward. And you have, I think, probably the perfect background and seat to have that conversation. And you're also at this really interesting juncture where you've had this great run across many important leadership roles, including your latest as the Chief Health Officer at Google. So we'll touch on all of that as we go forward. Is there anything that's just like really on your mind today or the last couple of days?
We're so good at knowing the problems, and we even know some solutions, but we've struggled with implementation. Mm-hmm. And some of that is because of a lack of resources for those who need it most. So there's a mismatch. Some of it is that we don't take a very good quality improvement approach to healthcare anywhere in the world. We add more things instead of trying to simplify. And so it's always exciting to hear all the ideas and where things are working well, but then thinking about how to scale those things so that it really does help every person. And you can imagine, I can't help but think, wow, AI could do that. AI could do that. I could do that. And so I get excited, I think, for the potential of what maybe the next 10 years will be once we sort out a number of things around AI, but I'm sure we'll talk about those.
On my bedside table is the book Abundance by Ezra Klein, where he's been talking a lot about that issue more from a government perspective of taking the history of the New Deal and all that was built during that period. How could we do that again? And I think simplification and use of technology and openness to those things and partnerships between industry folks and government, I think, are all in play. I want to focus for a little bit on the intersection of technology, AI, and public health in specific. And I think we've seen across many generations of technology that public health has been a slow adopter of tools. And some of that is a resource question. Some of that is a training question. And I'm just wondering if you have ideas for what would be a way in which public health could leapfrog current approaches by using technology effectively right now.
I think the opportunity for public health is pretty significant and obvious in many ways, partially because public health is so under-resourced around the world, and also because it often is managing crises, and those crises can pull your attention away from the ongoing mental health, chronic disease challenges. And AI can help improve the efficiency of responding to some of those crises. I'm going to give you a specific example. One of the ways that these general purpose AI models are showing their promise is in communication. And so they can take complicated papers and ideas or policies or recommendations around health and simplify that. The model can translate that into multiple languages, into various reading levels. It can make it more culturally appropriate. So it can be prompted to shape that message in a way that can reach the public. And the kind of thing that would happen to me as a local public health officer in New Orleans would be maybe there was a boil water event and we needed to be able to communicate to the public not to drink the water, what to do with their washing dishes. They would ask questions about their pets. You know, there's sort of all this series of things. And it takes more time than you can imagine to try to shape that from the best evidence and translate that out to the public. AI can do that now in seconds, what used to take us hours. And that then allows you to spend more time communicating with the public. It also allows you to think about the other ongoing challenges that you're trying to make progress on in the community. So communication, I think, is creating those messages and also doing it in a way that meets community where they are is a really important opportunity for public health. It doesn't require regulation. It's a human in the loop. It doesn't replace what's happening with public health practitioners, but it is a helper to them. You could take that kind of idea for communication and think about other ways that it could be helpful for some of the administrative work public health has, like writing grant reports, writing grant, the first draft, writing white papers on topical issues of import to the community. So there's a lot of low-hanging fruit, I think is the easy way to say it, that doesn't even have to get into sophisticated predictive modeling about infectious disease, which is, people gravitate to that immediately. I think really I'd like to see public health start simply. I might just say one other area, Claudia, where I think public health also could make good use of AI, and that's to educate itself. So again, and I don't mean public health is not educated. I mean that you're constantly learning about new things in public health. So there may be a new virus on the horizon. There may be a new way that people are using substances that you need to learn about. And that kind of research, AI is really good at also being a teacher. Grab me all the literature on this topic, synthesize it, let me probe that literature. So I think really for public health, it's an obvious resource to help them do some of the daily work they're trying to do to allow them to start to have a longer term view and really focus on some of those problems that maybe they just can't quite get to on their desk.
And I love that last example. I've increasingly been finding that when I want to get the scoop on something, I turn to Reddit. And because Reddit is like a real-time set of reactions to what's going on. And I think the other thing public health has been talking a lot about is it doesn't have a talking problem, it has a listening problem. And so I think they're creative corollaries to go be a listener and to really understand how the work is being experienced, what the issues are on the ground. So a Reddit listening tool.
Can I tell you a story about
Please,
that too?
Yes.
Yes and no. I do think that public health is actually, I think public health are really good listeners. And here's why I think that. I think it's because of an experience I had when I first became a New Orleans health officer. And I walked in from academic world, medicine and public health, thinking, well, here's what the data says. The leading causes of death are, cardiovascular disease and cancer. So we should build some programs around that. And the people who had worked in that health department for decades said, Karen, maybe just take a minute to listen to the community. And so we organized coffees in churches and at schools and all the places in community. And what the community said was that our biggest challenges are violence, mental health, and lack of jobs. And those wouldn't have shown up in the data because, first of all, the data is sometimes a little old, but also because the data is showing the end result of all those challenges, those social determinants, those other challenges people were facing. And it caused us to create programs that were reflective of what the community was wanting, but also does have an impact on cancer and cardiovascular disease over time. And the difficulty, though, for public health is you're so resource poor. I mean, as we say in the South, I had 2 nickels and some friends, and we would bring around our I'd run to the store and buy my own cups and we'd make a little pot of coffee and sit around to try to talk with folks. So you're so resource limited, not only for the funds to have cookies, but the funds to actually have the team to do the work and synthesize it. Again, another place that AI can be helpful is that it can take that information, that qualitative information, and start to make sense of it. But I guess I'll be a little defensive of public health. I think they're born to listen. They just don't always have enough time.
Yeah. One of my podcast guests a few months back was Yad Obermeyer, who does a lot of work around bias and AI. He was one of the people that discovered some of the algorithms that were inadvertently building bias from health data into recommendations and assuming that white people needed more resources. So there's, I think, great history there. His conclusion at the end of the episode was really interesting, though. He said, listen, I want to be really clear. I think the biggest risk is that we won't tap the power of AI to actually improve equity. And he said, yes, we should be concerned with bias and we should have our eyes on those things. But the opportunity we don't take is the biggest risk. And so would love to have you sit in that space for a minute, because I do think there's been a lot of attention to bias and we need to focus on that. But what are ways in which you see this addressing equity and bias issues when we actually embrace the technology?
I love that he's thinking that way because he's right. These new general purpose models are a really interesting type of technology because the promise that we've been seeing is that the models can be customized to individuals, to communities at a level that really truly meets people where they are. The way we say it is to help everyone everywhere find health on their own terms. And it's this health optimization team that we have that are behavioral scientists, decision scientists, and systems scientists who are kind of creating this blended set of science that is helping us think about, will the model work as a base model, not only globally, but also locally? And then how do we work with partners on the front line to test and learn if the model is helpful in rural Kenya, or in Tokyo, or in New Orleans. And some of that is because of the kind of language people use when they talk about a disease, like in New Orleans and many parts of the South, they call diabetes sugar. And so the model needs to learn those things so it can interact and feel more comfortable, but also interpret what people are asking and saying. And it's a kind of an incredible anthropologic, sociologic, but also health opportunity to really think over time the model could really, truly meet people where they are and not in a categorical fashion.
One of my last guests was Kasley Killam, who wrote a book on loneliness and connection. And we were talking a lot about the intersection of health issues and loneliness and talking about AI companions and bots and things like that. And she shared some amazing statistics around the percentage of people using AI today in the US that are using it for relational purposes, which was super interesting. And also the concerns that people, especially young people, are starting to turn away from human relationship. And we see declining trends in social connection and belonging and all those things. What do you see in that space that's interesting?
I think it's an important watch out. You can see it's a natural place that people might want to go to start to interact with the technology. And the technology is kind of designed in a way that it satisfies. So when you ask it a question, some of the models will say things like, "That's such a good question," or when you come up with an idea.
I've noticed that a lot of flattery.
And it wants to tell you that your business model is a great idea. And actually, sometimes what you need is pushback. On the other hand, you can imagine in some populations as an adjunct to or an augmentation to human interaction, it could be super helpful. So think about seniors that are living alone, and there's some parts of the world where they're incredibly alone, like in Japan. They will be isolated from their families geographically. They're not using a lot of technology in their home. But if there was a way to have some companionship that met them where they were, knows their family history, knows the things that they love, knows the songs that they love, to be able to interact with them, to keep them stimulated, could be helpful. I just personally wouldn't want to see it replace the human interaction. I feel like that in every aspect of AI, and maybe that comes from practicing medicine, where I feel that having AI tools to help me practice is great, but there's in my opinion, nothing that can replace human touch and just being with another person. But it can be helpful. I was a caregiver for my mom who had dementia. If I had some AI technology to also help interact with her, the songs she loves, the things that she cared about, it could have also given me a little bit of a break sometimes, or the caregivers that were also helping us. So I think of it as not a replacement, but as an adjunct, especially for populations that are at super high risk of loneliness and social disconnection. I do hope that we're really thoughtful as an industry in building these models in a way that keeps it really clear that I am an AI agent. I'm not a replacement for that human connection.
And that gets hard when people are building avatars and things, right?
I think the other part about it is going to be that we have a generation of youth now who are all going to be AI native. We say digital native, but now that's already passé, right? These kids that are coming up now, they'll only really think about the opportunity to interact with digital and technology. Think about all the kids that grew up with Alexa. They're just very comfortable being able to ask questions of those devices, but it's even going to be more exacerbated now. I think when robotics becomes more commonplace, that also raises some of the need for us to be very thoughtful as a society about the ethical challenges when there's a physical manifestation of the models that's not just in a computer screen or even through your glasses, but as the robots get more and more humanoid.
We've seen those movies. You've had these 3 seats of public health, policy, and a leader in a big technology company. If I asked you to simultaneously wear all hats, what advice would you give the government about regulating AI?
That it's too important not to regulate, and that they are a convener of stature, and as a result can bring together the actors in the ecosystem to think about how to define good performance, how to define what safe is, how to create a space of red teaming where we can push the models to try to get them to do adverse, harmful things. In all of that space, what's essentially happening is every maker of general purpose AI is creating their own methodology of how to assess good, how to assess safe, how to do red teaming. We rely on the literature when it's available, what people have published about what looks good. On the other hand, absence of industry consensus or a governmental steer is going to maybe have a few implications, one of which might be there could be harm, which nobody wants, and that would stop then progress towards the benefits, like things like, addressing disparities or access to care or improving public health messaging. The other thing that could happen is there could just be a lot of technology that gets out there and no one really knows what good and successful looks like. And it doesn't have to be true regulation. Sometimes what government does really well is be a convener of stature within the FACA and other rules. But, there are ways that they can bring people together and they can do some of that science around what is good, what is the methodology for assessing good and assessing safe. And we're actually very hot topic for us at Google because we've been doing this work for a couple of years and we're starting to pull in more academics, but we would love to have more opportunity for public-private conversation around it. In the regulated space, if you're going to use AI for clinical care, for decision support, whether it's in hardware or devices or just in clinical practice, I think there needs to be certainly regulation. It needs to be probably in the short run built on what we have available, FDA authorities mostly, but there are some other authorities potentially in the U.S. and then, of course, globally. But it's also true that we may need to rethink the way that we regulate AI. And so an example would be, historically, you'd look at the performance of an AI model to read a mammogram, and you'd look at the area under the curve to see how well it performs related to a gold standard of a human reader. The opportunity now with Gen AI is that it's not narrow. It doesn't just do one thing, which makes it hard to evaluate because it can do just about anything. So we've actually talked about regulatory approach that's more like physician oversight. When physicians go through training, they have to take board exams. They have to pass a variety of standardized patient exams to show that they're competent to practice medicine. That might be a way to do it. And we've actually done some research in that space where we have a medically tuned model and we have it take the USMLE, which is a medical exam. And then we've given it OSCEs, which are these standardized patient exams, and we've even had it do human standardized patients. And we're doing some work like that with Harvard right now out in the real world. But it's an example of you should regulate. And the question is how do you do it? And if you only try to regulate each aspect of the narrow AI, what it could do, you miss the opportunity for it to be a part of a team, a healthcare team, or a science team. And so it's a kind of a rethinking. And so I would like government to continue to get smart about what the tools can do, what they shouldn't do, where they can go wrong, and then think about what kind of a regulatory paradigm might be useful there.
In your ideal world, would that be both state and federal, or would you prefer to rely on the federal mechanism?
I think it would be ideal if there was a principled approach that every government around the world agreed to, because there's several reasons. One is that the needs for the technology to be helpful in things like filling gaps in care or supporting community health workers on the front lines with evidence-based guidelines to treat diarrheal disease are ex-U.S. They're outside of the U.S. more than they are in the U.S. So think about, rural India or Indonesia on an island. There's a bunch of parts of the world where people need these tools to extend care or augment more than we even need them in the U.S. Some of those countries, especially some smaller low and middle income countries, don't have infrastructure even yet to regulate AI. They rely on global organizations to help them think about even vaccine approvals, et cetera, right? So there needs to be some principled way that these governments come together. And there are groups working on that. There's a group called Health AI, which is designed to not develop the regulation, but to help governments understand what's coming, what the potential is, and what are the things to think about in terms of safety, et cetera.
Last time I saw you, we were talking about an article that had just come out in Health Affairs that you wrote with Mark McClellan and others. And you were really compelling in saying one of your takeaways was, which is that in a future that we might envision where public health is everyone's goal, it can't just be governmental public health, that we need new models of partnership and new bearing of that weight across a much broader set of characters and organizations.
You said that much better than me.
No, that's straight from you. I would love to have you expand on that a little bit, because that was the result of some really interesting work that National Academy of Medicine took on to really think about what that future would look like.
Yeah, I wrote a lot about this in Public Health 3.0, which was some work I did when I was in the federal government. And that work was very oriented towards local public health needing to recognize that it had a convening role in the local community to bring together public-private partnerships to address big systems-level challenges that public health alone couldn't address. So things like social determinants of health, which affect 80% of your health outcomes. I think everyone kind of knows that who's listening to your show. There are a number of other threads in that relate to, it creates an opportunity for things like data sharing, appropriate data sharing for purposes of community health improvement, or setting shared goals around what health looks like for a community. It is a very similar model as you step up to state level and then to federal level and probably global, that public health is what we do together as a society to create the conditions in which everyone can be healthy. It's not one entity's responsibility alone. I think what happened with public health a bit, though, is they, as a governmental practice, felt more and more responsible and accountable for all the things that were creating difficulty for people's health, and as an under-resourced part of the ecosystem, stretched themselves and didn't do as well at keeping up with relationships in the medical sector, so healthcare systems or payers, or the business sector, employers. And that, again, goes back to the things we talked about in Public Health 3.0, but became, I think, really evident in the pandemic, that public health was a bit on its own island and wasn't able to call a friend to get some help. And throughout history, public health, the business sector, medicine have worked together in a variety of ways. And of course, public health and medicine were one field. Years ago, they just diverged over time. But it's a bit of a humility exercise for public health to say, we do need to work with others and we need friends. And there's some things that medicine might be able to do better than we can. There may be some things that the business sector can do better than we can. And you and I talked about some examples of where that's been playing out in different ways in the front lines, like in the Denver area. There's a partnership with the Denver Health, the University of Colorado, and the Public Health Department, the city, where they've sort of split up some of the statutory duties so that public health can focus on things like food safety, but the epidemiologist and schools of public health can help with the surveillance work. And in Kansas, the Lawrence Douglas County has done something similar with the School of Public Health and with the local government. We did that in New Orleans with Tulane and with the business sector. So I think any ways that you can partner is always a bonus. One thing I will say, though, is the medicine public health partnership can be challenging, because what people forget sometimes is that medicine is predicated on this idea of what you do for one person, whereas public health is predicated on the idea of the global good, the common good. And you can take examples of like contact tracing for tuberculosis. You're not just thinking about treating the person with TB like you would be in medicine. Public health is thinking about exposure of the whole community. And so privacy becomes different. Data privacy for HIPAA in medicine, very close hold the data. In public health, there's a responsibility to community, so you need to do case tracing. If you can acknowledge that and talk about it and understand, like when public health says it needs data, it doesn't need to know the person's name and like a lot of detail. Sometimes it just needs to know de-identified information to do better surveillance. And it may sound, I may be going into a little bit of a deep hole there, but I find they get stuck in that because medicine's goals sometimes are different than public health and vice versa, but they have a lot of overlap. And so there's plenty of ways that they can work together.
I remember during COVID, I was running a data network in California, and we were getting a lot of vaccination data and a lot of lab data. And we went to the state and we said, we would love to get more of that data. So because we know what patients are attributed to which doctors, we want to push that result to their PCP. And they said, well, we don't know if we can do that from a privacy perspective. And we said, well, who should we talk to? And they couldn't figure out even who had authority to make that decision. We thought, well, if nobody knows, let's just keep on asking. We're not going to take no for an answer. And eventually we figured it out. But it was almost like everyone had the ability to say no to that, but nobody could say yes.
Look, I think you're raising an additional point, by the way, which is one of the struggles public health has, and that is the jobs, the resources are all in healthcare. And so policy work, tech and IT work, legal work, people gravitate to knowing healthcare. There's a paucity of that in public health, which also means there's an imbalance of power at the table. And so, anything that we could do as a country to kind of get more, exactly. Public health law is an area where, especially going into the future, if we're going to use more AI, we need to make that system more robust.
We have a shared history and passion for data sharing, and you led ONC, which is now ASTP, really to be the voice of the future of technology and healthcare in the government. I get a little defensive when people say, what did the HITECH Act really do? And it's like, well, hello, we now have every doctor using an EHR. So while there's plenty of stuff that could be criticized, that was a huge change. I think on the data
every country on the planet wishes that they had done it.
But I think on the data sharing side, for sure, there's been progress. I don't think it's gone the direction that many of us wished it would have. I'm just curious how you see that. What do you think have been our wins, and where are the areas where we're really still stuck?
This would be a full-hour podcast.
Maybe
more. I think on balance, it was a great thing. It is enabling us to build Gen AI and make that helpful for population-level health, make it helpful for individual care. I think it's unlocking the potential of AI to improve access to the best quality, most affordable care anybody can ever have. Absent having that data, we wouldn't be able to do that work. I think that the frustration with electronic health records was and is partially that there was a lot of entry of data by very expensive parts of the health system, mostly docs, but also nurses. And there wasn't a lot of return on investment. So people were pushing stuff into the system, but they weren't able to get a lot out, especially in the early days. Over time, maybe it took until about 2018 is the year I would mark in my brain for when my physician friends, including my own husband, started to feel the benefit of, now when I'm on call at night, it's very easy for me to see what's happened with my patient or someone else's patient that I'm cross-covering for, or I can follow up in the evening about a test that I ordered. And we have all these other good examples like Flint and like all these ways that the data has been helpful for individuals and for public health. But it took some time, maybe a decade, to get to that place. I think the other thing that was frustrating in the beginning was, and I wasn't there at this time, Claudia, so I don't quite know all the thinking that went into it. But when we developed the Meaningful Use program, we developed it under, I'll say, duress. And it was duress of the fact that we needed to push the high-tech money out the door as a country very quickly. So that money passed through providers into the hands of existing electronic health record companies who had proprietary data standards and were able to quickly stand up this infrastructure for clinicians, but that infrastructure didn't have open non-proprietary standards. There wasn't time to build those, to agree to those, and so the systems didn't talk. And so interoperability was ridiculously hard. So that's a time pressure thing I think a lot of folks don't realize. I think the other thing that happened is we built those systems and that mindset in a time when the prevailing technology notion was, software comes shrink-wrapped in a box, and you undo that and you stick it in a computer. The smartphone came out, just about the same time high tech was passed, and that began the iPhone began to completely change the way we thought about where a computer would live in your life. It wouldn't just be on a desktop. People could have apps and they could go to sites and mobile. That push and pull changed the way people interacted with technology. But the EHR systems stayed more in a server-based, shrink-wrap world. They weren't quite caught up because that's what we were paying for in the system. So it took a little time to kind of do that leap. It's so easy in hindsight to say we should have, we could have, because we really thought that that was what we were kind of building for. But I said a few minutes ago, every country in the world wishes they had done it. I do think what's exciting in this generation of IT adoption in healthcare is actually that there's been a lot of learnings from what happened in high tech, and some parts of the world are creating a different kind of system of documentation and IT enablement of healthcare, that one that is directed by early governance, requiring interoperability, linking that to payment, and also one that's very much about patients having access to their data, people having access to a longitudinal health record. And so, and some of that is places like in Indonesia, where they had a COVID app and they said, oh, wow, people are really using this. They like knowing their vaccine record. Let's just start putting more stuff in that app. NHS does that in England. So they went, oh, it's actually, if people have something useful they can use in that system, they will. And we don't need to put all of our energy in building up the IT for the healthcare systems. We need to also make sure people have access to their data. So I'm hopeful that this next gen is going to be open standard, respecting privacy through good governance, but also being much more centered around the person. The downside to all of the knowledge resting inside of an electronic health record is that it is all the perspective of the healthcare system and not the perspective of the person, the patient. Getting that story told in a more wholesome way is enabled by things like cloud platforms that can pull data from the electronic health record, from wearables, from exposure to air quality, and creating a population and individual level picture of health. We're doing work like that actually at Google with some different partners like Taiwan and a company called TELUS in Canada, where they're trying to, it's an and, right? And actually, we wrote the strategic plan during my time as national coordinator, was that the EHR data was but one of many sources of data that went into telling the story of someone's health. You can imagine how well that went over with some people. But but it is the truth. If you're going to drive health for individuals and communities, I think you have to know more than just what the nurse or doctor or whoever saw in the health system in that episode. There is a better way, and I think it's something that we're proud to be trying to help solve.
And I love how that leap from ONC to Google allowed you to actually make real on that vision and do the thing. Thank you for your service across so many fronts. And can't wait to see the good trouble you're going to get into next.
Thank you, Claudia. I'm gonna try to always be in good trouble.
Good trouble.
It's always good to see you and great to talk to you.
It's great to see you. Thanks. It's easy to be kind of breathless about the potential of AI. I remember feeling the same way about other breakthroughs, the internet, cell phones. I even felt that way about mapping software. But at the same time, I'm more distracted, less present, and less willing to dive deep because of my reliance on all of them. And let's face it, these technologies are shaping everything from our democracy to how we parent, love, and work. And honestly, it would have been hard to predict this outcome. AI surprises will be even bigger. It's a frontier we don't fully understand. As we stand at this threshold, the challenge is not just building the technology, but ensuring it serves humanity safely, ethically, and in ways that make us healthier and more connected. This podcast was created by me, Claudia Williams. My podcast producer is Avery Moore-Kloss. Check out the show notes for more information on Karen DeSalvo. There is more information on my background, this podcast, and our guests on our website, www.theother80.com. Until next time, I'm Claudia Williams.